And as you introduce yourself, would you share not only who you are in your position, but how you got to the work that you're doing now in the HIV response? And in particular, how have you seen and experienced resilience in the HIV response?
So I am Luann. I am the director of an organization called PATA, which stands for Pediatric Adolescent Treatment Africa. And PATA essentially is a network of health facilities and providers working in pediatric and adolescent HIV in sub-Saharan Africa. Are very engaged with the faith community, knowing that really so many faith-based health services really provide care and the delivery of health services to so many people in our region. Just myself personally, I'm a social worker by training. I've worked in the HIV sector for more than 20 years, but really in managing different HIV projects over the years. I think really resilience essentially is about people living with HIV, families, communities, and of course just, you know, ordinary people showing up every day, standing up, making sure that we are there to provide the support, care, compassion. You know, while I think sometimes things have not always been easy with the faith-based community in terms of being able to provide comprehensive health services, you know, the faith-based community has always really been there from get-go in terms of providing care, providing support, really trying to fill some of those gaps. So I've always seen the faith-based community really being a critical partner in the HIV response, and really being an enabler and providing that real linkage.
Yeah, so I was saying my name's Derrick Malumo. I am Executive Director for the Prisoner Reintegration and Empowerment Organization. So my cry with my experience, because I was in one of the facilities before. So during my time inside, I observed with sadness that the church will be able to come in and, you know, minister to the prison inmates the word of God. I observed that a number of inmates, as they are transferred within, you know, prisons, from one prison to the other, there is no, you know, facilitation in terms of their continuum of care. So in 2009, a zero prevalence rate study was done by the UN AIDS, and it was found that HIV AIDS prevalence rate in our facilities, particularly in Zambia, it is twice high compared to the general community. In our prison settings, currently, it is 27.7% compared to 11% in the general community, which is twice high. The issue has been only the incident rate. That study has not been done to determine what could be the reasons for this high prevalence rate in HIV. And for women in facilities, the number of women or the population of female prisoners is smaller, but HIV AIDS in the female population is higher. What we need now is to have a study on zero prevalence on the incidence, I mean. So we need to have a study to know where is this HIV, why we have such a high prevalence rate in terms of HIV in our correctional, you know, facilities. And also we are also talking about, you know, adherence. Adherence to treatment is not really ensured because inmates have to take care of their own health. That is the challenge. We are also talking about the mentally ill who are on ARVs. So the mentally ill, it is very difficult for them to actually guess the time of taking medication. It is very difficult for them to know that this is the right time to take medication. We are also talking about the poor diet, you know, because the government is not committed in terms of ensuring that diet of prisoners is ensured. So the diet is very poor, of which it is very difficult for inmates who are on treatment to adhere as well to treatment, because the drugs are very strong. They need, you know, someone to take, you know, good diet and at a proper time. So this is one of the challenges. Now, if this is a problem, budget constraints, then the government will always need, you know, partners to come on board to complement, you know, efforts. So this is where personally and as an organization, as a director of this organization, as a founder, I have felt a need for the church to come on board, because the church is able to raise resources. The church is able to, you know, to do anything to support efforts of government, because the government, particularly the correctional service or the prison service, is maintaining an open door policy. So an open door policy has allowed the churches to come in and you know, minister. But then the challenge is that this is all what the church can do, which is very sad. Even when inmates come out, those who are on treatment, they do not get any support whatsoever from the churches.
My name is Kunal Kishore. I work with a civil society organization called the India HIV Aids Alliance, and we feel we are very fortunate to be leading the responses for people who use drugs, including women, including young people, and including those incarcerated. The reason I started working in this sector was very personal, in fact. I'm born to a father who was a very well-known medical doctor, a surgeon himself. We lost him to some form of, you know, the problem that we are today talking about between alcohol and prescription drugs. And growing up, and I was just 10 when this happened to me, and I've been always thinking about doing something. And from there, since then, the first job that I got involved with was, you know, working with the premier institution in the UN space, the UNODC. And over a 13 years journey, right from an entry-level job as a UN volunteer, I ended up leading the drug prevention and health program in South Asia for UNODC. What moved me most was how we look at people who use drugs, how we look at drug use itself.
So my name is Otieno from Kenya, and I work with young people, and I'm a psychologist by profession. At the same time, I'm a mental health advocate, working with young people in the community on HIV programs. So my journey started when I was diagnosed and found that I was positive. So being a young person at that age, just lost your mom, and you being informed that yes, you've turned positive. And within that time, I was diagnosed with depression at the age of 11. I think that's the point where I started trying to find myself at that younger age, and the support that I got from the various people in the community, especially the faith community, because basically I was raised by priests. As young people, we go through a lot of mental health issues that really impact on their well-being, their health. But with the right support system in the community, which to me, I really got it from the faith community, which is the priests that I was brought up with. So I established an organization named Alfajiri, and I'm the leader of the Alfajiri, which started in 2015. Alfajiri does access to quality health services for young people, but through integrating mental health into it. So the point of resilience for me is every day when I do my work, I remember that this is not just my journey. It's a journey that I have to walk with every young person.
For each of you, I'd be interested to hear some suggestions about how to shape stronger collaboration between faith and non-faith actors, specifically between faith actors and the communities that you work with and represent, that would allow a more effective HIV response. What recommendations or suggestions for collaboration could you give us? And Brian, if it's okay with you, I'll turn to you first with that question.
There's a lot to be done within collaboration between young people and our faith communities, because there's already an existing gap between young people and the older generation, like intergenerational gap that already exists. Having dialogues, like increasing dialogues between the faith communities and young people living with HIV, and also trying to understand how these young people would be of use, not just there to be seen, but how best can we engage young people, like the meaningful youth engagement aspect. The other aspect is increased partnerships with young people. Like, to increase collaboration, we need to have young people being engaged as partners, have young people be placed at a level that they feel they can manage and provide an action from how they're engaging with their religious leaders. So for me, the three are very key: dialogues, partnership, meaningful youth engagement for the faith communities and the non-faith communities as well. So that
two things where I feel faith leaders are very uniquely placed to change the game or serve as game changers are: one, humanizing the drug use issue and humanizing people who use drugs, basically. The second most important part where I feel a lot of convening and a lot of convincing is needed is basically building a synergy with the health, human rights, and particularly the larger policy reform sector to ensure that harm reduction, HIV prevention services can be given to people who use drugs wherever, whenever they need it. I think there's a bigger problem of also how morality, how we look at the problem itself plays out. So I think faith fits in very well in that space. And what I would like to see change through faith leaders in that sense is how best could faith play a role in humanizing, as I said, the issue. What happens is when you put criminal sanctions, you just keep them away from any social welfare, any health. So that's one. And second, humanizing would also address the larger barriers, be it social stigma, be it institutional stigma. And Corona is, it's very interesting we are having this conference because Corona is just, again, another reminder that we think stigma is less, and just then it reminds us that stigma could still be one of the biggest barriers in ensuring that people have access to health services. Two things I wanted to highlight. So if you take the example of India, where we are engaging faith leaders on very important matters of people who use drugs, and what we are learning here is that if the religious leaders are on your side talking about things that we are trying to convey through all these mass campaigns and prevention programs, we feel that you could touch most people who are following one or the other religious gurus or faith leaders, or you basically are doing a better prevention, better awareness, mass outreach than the conventional programs. So in fact, one of the religious institutions with whom we have partnered in India, that was the question that was asked to me by the senior most guru. He asked me, why have you come to us when you can already run mass campaigns and reach out through journalists, through a conventional prevention program? I simply said to him exactly the same thing. I said, sir, you are currently reaching out to several hundred thousands of people. If you could just include a line or two on humanizing the drug use issue. Most people in our country are currently not accessing harm reduction services, largely because of stigma. What if they are given the right kind of messages from the word go? And we are seeing the high mortality and morbidity largely because people go in very late, when they're already infected, when there's a lot of risk behaviors, or when people are about to die. So that's where you could intervene, and you're very strategically placed. So the concerned guru, he understood, and since then he's been our champion. He's been leading us in helping develop the flagship harm reduction module. The other thing I really feel we need to be talking to faith leaders about is a little bit going beyond prevention and looking at treatment. In our country, for instance, we have a number of faith institutions, particularly between the Sikh faith and the Christian faith, where de-addiction centers, drug dependence treatment centers, hospitals are run using the religious or faith platforms. Now, what we are witnessing there is people also experiencing sometimes non-scientific, non-evidence-based approaches to dealing with people who use drugs. What we have done is we are in the process of sharing evidences on what minimum standards of care means, also with the faith community. And what faith community in turn can do is facilitate the role of bringing stakeholders as conveners. We also need to see the important role faith can play in terms of building consensus between faith and the evidence or the scientific world, so that we are removing the morality and removing the stigma around things much more strategically than we have done so far. This whole division between faith should only be doing the classical prevention work has also not worked. So I think we need to see a larger role for faith, and faith, I feel, is doing quite good in terms of helping build this consensus that is required with the science world, with the scientific world, where evidence is important. And once we do that, I feel that 90-90-90, or what we now call as 95-95-95, will be very much achievable.
Really investment and participation in local structures and the organization of, local AIDS committees, councils, and obviously working at different levels from both a district right up to a national level, where we really do see the participation of the faith-based community being really important in terms of developing the planning, but also we also know that they're so critical in really delivering the actual services. So making sure that they're part of devising those plans and being part of the conversation as equal partners. I think really importantly, faith-based partners are such an important entry point in terms of in the community, reaching caregivers, working with families. And historically and ongoingly, their roles in sort of education and prevention and real care and support. But I think really this opportunity to also stand firmly as advocates in terms of, where are the gaps, what's not working, how are we sort of reprioritizing, where we're seeing that we're really falling behind. And in a way, is HIV to some extent falling off the table? How do we reprioritize children?
Can you give some concrete examples, particularly for people who may not be familiar with the work with young people and with children? Can you give some concrete examples of what the meaningful participation in the HIV response looks like?
So locally, we have a network of young people, Y+, that has managed to reach out to a number of young people, and they're already implementing programs by themselves. As on the global level, we've had a number of youth networks like the Y+ Global. These are organizations that have managed to bring an impact at a global level just by working within the collaborative measures of working with young people, for young people, and by young people.
The real involvement in terms of really reaching out to, networks of communities of women living with HIV, caregivers, mothers groups, of course, networks of young people, but not just sort of reaching out and bringing them into, to have dialogues, but really involved in the sort of thinking and planning and as different sort of programs are developed, are young people and caregivers really involved in terms of how those are going to be developed, especially if they impact on their community directly. Often these are really driven from faith-based communities themselves. And also, I think importantly in terms of the sort of the community monitoring. So really, engaging with the community in terms of how is the message received. So where we see community health workers, actively in the community, driving, sort of finding children that in a way have been lost in the system, a real drive to sort of be out there, driving early infant diagnosis, keeping mums in care in terms of care and support. Vulnerable households, vulnerable communities, really being supported in so many different ways. and most importantly, you know, really trying to find a safe place, a safe family.
What would be your, dream messages or dream advocacy that faith leaders would do or say using their influence that would really make things better for children living with HIV and children affected by HIV?
I think for me, you know, there's a real sort of similarity. I often think faith leaders and health providers, they sort of have this powerful position as being gatekeepers. I mean, gatekeepers in terms of, you know, how we access and experience service, but also, you know, how we understand the world in terms of our sort of moral fiber, if I could. So I think for me, it's about the positionality and really seeing how faith leaders can use their position and their power in the best way possible to ensure that their role is both enabling and empowering, and a role that, you know, ensures that we stand up to all forms of stigma and discrimination and human rights violations. I mean, I think for so long, our religious personal belief systems, often sort of compounded by laws or systems, you know, result in so much bias and judgment. And these ongoingly continue to be the biggest barriers in terms of really making inroads in the HIV response. The biggest real sort of plea is really to overcome the sort of silence and the stigma of silence around HIV and the sort of kinds of strange sort of cultures that we create around, you know, shame associated with HIV, sexuality. This is a huge opportunity to shift that, and we've seen so many great examples. And I think, you know, faith leaders are at the forefront and instrumental in really setting the tone in terms of how society responds to HIV.
And two things that really come out for me is, one, the injustices in the community brought about by either the community itself or the state or the governments that are in place. These injustices include the lack of the voices of young people in the community or decision-making platforms that religious leaders with their voice are able to push for this, and young people are able to get their position within those decision-making platforms and even come out and say, we are supporting young people to do this. The other aspect, I'm looking at the harmful laws and policies in the community. So how do they make sure that they influence these policies that are supposed to work for young people? How these policies are not going to hurt young people, because there are harmful laws.
I want to ask you about any opportunities or challenges that you faced when collaborating with people from faith traditions in the work that you do.
The rigidity and lack of adaptability of religious communities. Like that we are they are very rigid, or the faith communities, we are rigid in how we do things. We are still stuck in the traditional ways of how we do things, yet change is inevitable. Then the other thing is adaptability, just adapting to how we need to, like, being a bit flexible in how we do things. We need to shift away from the traditional ways of doing things and try and be adaptable in how we try. So these are some of the recommendations I'll give in terms of my interaction with the faith communities for the longest period. Yeah, in terms of reaching out to young people and mental health, and again, the use of art for advocacy and impactful change in the community of young people and young people living with HIV.
You know, just the sort of experience of the inflexibility, the rigidity, the sort of cultural sort of stuckness, for want of a better word. And we do see amazing examples of many faith leaders, you know, maybe who've stepped outside of the sort of rigidity of a particular sort of stance or teaching, who've really done quite sort of brave things because they're the right things. You know, many people growing up in a faith community, it is really like a home. It is a safe place. It's about music. It's about song. It's about connection. and it's about care and compassion. So I think if we could try and focus more on those real positive things, the things that bring us together, the things that build peace, you know, this is where I see the real strength of faith-based communities, being able to use the position that they have in terms of holding not just governments accountable, but also their own peers, and sort of by leading by example. So I think, you know, in my experience in the HIV world, it's always been, you know, that one faith leader who sort of stepped out a little bit and stepped up a bit differently, and was able to really name things and call things as they are. Really, you know, making a huge difference and being able to bring other people along with them.
I'm wondering if you could give an example of faith leaders or a faith leaders stepping out and doing what you said, brave things that are the right thing. I'd like to just hear if you could describe a situation or an example of that happening.
You know, many examples of, you know, working with a nun in Zambia who really, in the face of real sort of criticism from the church, you know, felt that absolutely, you know, there was absolutely no way you could be talking and working with young women without really giving them choices in terms of their own prevention, just in terms of care and support. You know, in the face of many, you know, young people or families either being sort of ostracized from their community, orphans, vulnerable children in villages, you know, absolutely, there's always been a faith leader there making the hugest difference.
And I think that it's important that we recognize what these brave faith leaders do, ways that they're willing to step out and do what they know is right to protect people's health and well-being.
Yeah, so for me, I think it's my personal story of how a faith leader took me, and all along he used to tell everybody, like, I'm the son. Basically, in the faith community, in the Catholic religious community, that priests don't have children, but he took me as a son, and I was always being introduced as his son, and I used to call him dad, because it was not, people will not really understand how a priest will have a son and how I'll call him a father. He took me in because he knew that I needed that support, and he went beyond the extra mile of not caring what people think about him having a son, despite being a priest in the Catholic Church. His relationship with young people in that community was so well, because he will really be open about real life issues on young people, and he will address them outside being a priest. He will always start and say, I'm a priest, yes, but now this is real life situations that require real life solutions. And the way he used to address stuff will really make me feel like the faith community can really do better. And sometimes we just need to adapt and have a human-centered perspective.
I wondered if you could say a bit more about how you are using art. What is the art and the art projects or art project that you're using in your work, and how does that support young people living with HIV?
So what we do is we use art to help young people express themselves, like using an expressive form of art on how young people would understand their treatment, how young people would understand why it's important to adhere to their treatment. So one of these programs we're doing is called Safe Spaces. So Safe Spaces is where young people come and use poetry, drawing, that is constructive art, and just have storytelling moments where we're able to construct stories and create personas of the kind of young people would want to have, the kind of dreams that we want to inspire. This is where young people are taking ownership of their treatment schedules, taking ownership of the clinical schedules, and even how they view life beyond just being HIV positive. How this program has really helped, the facility we are working with in Nairobi is the leading facility in adherence in Nairobi currently, because of the program we're currently using on art. And this is a faith-based facility. Mater Hospital is owned by the Catholic Church, And it has really shown an immense impact on how the faith communities can collaborate with young people in terms of just bringing in new ideas. Sisters and nuns who really integrated how young people really want their things to be done. And through using art, we've been able to manage the adherence, like improve the adherence of young people and viral suppression of young people within that facility. And currently it's the leading facility in Nairobi, and it's serving as a best practice for other facilities. Then the other one is more focusing on art therapy. And the other program we're doing is more focused on working with creatives.
As you look forward, what specific steps do you think faith communities should take to enable their own renewal on HIV in the areas of increasing access to prevention, testing, treatment, care, and support, promoting human rights, addressing stigma and discrimination, and/or building bridges of collaboration?
Acceptance for certain key populations, we are still far away when it comes to drug users. And what faith is doing is helping build that consensus based on some sort of a working arrangement that we have developed. So what we are doing is, with the blessings of the senior faith leaders, we are training the second line leadership in the country across religions, across the faith groupings in India. And that's been done based on a manual that we are jointly writing with faith leaders.
In a practical sense, is this sort of reprioritization of children and families, and really making sure in terms of sort of finding children, such an important area right now, especially as we know we've just hugely missed our targets.
One thing that really comes out key for me is increased engagement beyond HIV. Like, there's need to have a broader look, and that includes going beyond the scope of HIV and bringing in the aspects of integration of other programs and other initiatives that will help with sustainability. And the other thing, which is now which I've mentioned, is having or planning for sustainable programs. There are more adaptive ways of how to engage. So having that open mind and being flexible in how engagements are being done and programs are being run can really help improve religious leaders' position in how HIV programs are being run. It's trying to work with the local capacity, like trying to borrow more on local capacity that's already there and existing, in that we need more collaborations at local level and community level, because this is where like most of the ideas and need is, compared to the higher level that we've been engaging initially. So I think those are the few that I can take to increase the renewal and collaborative measures within the faith communities from my side. Thank you.
So turning to Derrick, do you have lessons you've learned this year while reaching out to communities, supporting them to meet the needs created by COVID-19? And are there any best practices that you could share of collaboration with faith leaders? Alternatively, are there suggestions you have for how faith leaders and communities could better support the work that you do and have done related to COVID?
That there are 10 COVID cases, new cases in the Zambia correctional, service facilities. Congestion or overcrowding is still a very big challenge with our, facilities. COVID-19 require people to ensure that there is social distance. If we are to prevent COVID-19, we are talking about social distance. We are talking about, good hygiene, washing of hands. We also need to have clean sanitary, facilities, Now, when you look at the population of prisoners, it is very high. We are talking about over 21,000 prisoners against the original holding capacity of 8,600. Now that we have 10 COVID cases in the facilities, we are very much worried, because now these inmates have to sleep very much close to each other. Of course, we appreciate that there are efforts that the government has put in place through the correctional service to have one of the prisons made as the quarantine center or an isolation facility for those who are, found with coronavirus. But this will not really be enough, because by the time someone tests for coronavirus, they would have already spread it to others. Now, when we talk about coronavirus in terms of who does it really target, we've heard that those who are on treatment, who are on ARVs, most times they are affected. Oftentimes they are affected because of the weak immune system and so on. We have also the elderly in our facilities who need to be protected. We have circumstantial children who don't even deserve to be in correctional facilities. All these will.
So beginning with COVID, I would like to touch upon. So just everything was at a standstill. So you had about what 2.1 million HIV people living with HIV in need of ARVs. You had about 851,000 people who inject drugs needing harm reduction services. So what we did was we just reached out to our faith leaders who we have been working with. We raised enough cash, we raised enough food items, both and then we also managed to mobilize a lot of let's say safety kits, emergency medicines, and we could also find resources for supporting drug users and people living with AIDS to substitute for the loss of. So what you realize that in a situation, a pandemic-like situation, and in a situation where you have a lockdown where everything is frozen, literally, and people in millions needing services, faith made all the difference for us. COVID was phenomenal experience in terms of showing both resilience and revival of what community groups and civil society can do. As we speak, I just wanted to tell you that we have distributed close to 2,000 ampules of naloxone. So you have to understand, it means 2,000 lives saved. We would have lost these lives had we not been supported by the faith leaders.
I wanted to see if you had any further recommendations that you wanted to make sure came across.
The opportunities are plenty. Let me first talk about the environment. We have the very good political environment that gives the opportunity for the church to comment on the governance issues. The church in Zambia has a lot of opportunities in terms of governance, because the government, political leaders respect the church a lot. So meaning that the church has that opportunity. And also we can talk about the legal environment. There is nowhere in the law where the church leader can be arrested for advocating. So opportunities are there, except that maybe what we need is sensitization programs. Voice of the church is louder. The church is respected compared to actually us. What we are going to do as an organization on our part is that this is an eye-opener. The Interfaith Conference, the Renewal program is meeting is an eye-opener to the organization that actually we can approach the church to sensitize them on the need for them to come on board, because their voice is louder.
The real sort of development responsibility in a way, and in some sense that can be so transformative. I think the transformation is also really around attitudinal change, changing attitudes, really leading by examples, and really shifting sort of away from this sort of historical, I don't know if I could call it sort of punitive or rigidity, to really a place of dignity, respect, and compassion. And I think for me, absolutely faith-based leaders hold this opportunity to really transform the space and hold, not just themselves and their peers and governments accountable, but really being able to move communities along so that we really become a more caring and human society.
As religious communities, because I'm part of that, and I would really say we're already doing so much, and we're already doing a lot, and doesn't mean that the fact that we are giving recommendation means that there's nothing being done. There's so much already happening. However, we need to increase or review how we engage in terms of our impact in the community, our impact to the people we serve in the community. And I'll just go back to the fact that there are human faces behind the numbers we serve. There are human faces behind the services we provide.
It is really exciting that today I can sit in a conference and attend a conference where we have church leaders discussing HIV AIDS in prison settings. Personally, for me, it is a faith building. It is encouraging that to know that the church is interested. Today, I can be in this conference, and I'm excited, and I can't wait to address, faith leaders. So, personally, I'm really, encouraged, and I think I will do my best to continue the advocacy and give out the necessary information that the faith leaders may need to act on, because I think what they don't have is information on really what happens in regards to HIV/AIDS or prisoners who are living with HIV. The church should come on board to join voices with us to say prisoners' rights are human rights, and then we cannot leave anyone behind, so including prisoners, because prisoners are a key population. They are now identified as a key population. So there is a need for the church now to come on board to join voices with us. Then we are also talking about stigma and discrimination in the public health facilities. It's a situation where a prisoner who is on treatment has come out and goes to a public health facility to try to access, treatment or drugs. But immediately the public health care worker learns that this person was actually in prison and is on treatment. They will not take this person or look at this person as a patient who has come for a service. They will look at this person as an ex-prisoner. So the church can come on board, bring the healthcare workers together to talk to them, to say, look at a person who has HIV, who has come to a facility as a patient who needs a treatment or who needs a service, not as an ex-prisoner. The church can come on board. We join hands to sensitize healthcare workers so that adherence is maintained.
In terms of what could be done as models, as I said, in the mass outreach sense, I feel we have not engaged faith leaders sufficiently, quote unquote, in the context of harm reduction. We have engaged faith leaders in the broader HIV space, but not on harm reduction. So I think we need to bring the focus, narrow the focus more on faith and harm reduction as opposed to faith and HIV in the general sense. Faith leaders need to be more explicit when it comes to people who use drugs and harm reduction. We have prioritized faith leaders more explicitly on harm reduction and more explicitly on specifics of bringing science and faith together and bringing issues of drug users without overshadowing it with terms like key populations in the general sense. Even from UNAIDS, it is very important to start talking harm reduction without necessarily letting it overshadow by the broader HIV response. We also start looking at data more explicitly. So when we say new infections, we need to look at who is this new infection amongst. We are trying to now use faith as a safer space to be a little more explicit than we have been. So I would very strongly say two things. A, harm reduction works, and B, support, don't punish.